Hi, my name's Kjell Hult. I'm an anesthesiologist in California. Olden days, you'd get a little bit of gas, maybe some halothane or even way back ether, and then a ton of opiates. They would try to keep you pain-free, but there wasn't a whole lot of finesse to this. And now we have new drug classes. We've got to find something better. A drug called sabrinopidol. It binds at the opiate receptor, but in such a way that it doesn't create the same abuse potential. It's not nearly as addictive. So that's a new drug in development, and hopefully we'll see good stuff from that. A drug called oliceridine. That binds a little differently at the opiate receptor. It triggers a different cascade that minimizes respiratory depression, which is how you die from opiates. It depresses your respiratory rate so much that you just stop. So this is effective as analgesic, but with minimal respiratory depression. Or we could take an old drug that we know and love and use new technology to make it safer. A good example of this is a drug called sufentanil. Very, very potent opiate, but also it's got a very potent rush, a euphoria associated with it. So it's a really potentially addictive drug. If you find an anesthesiologist dead in a call room from drug use, 9 times out of 10 it's going to be sufentanil, because people who have access to this drug and know its effects, it's a very, very dangerous drug. So they've started with this incredibly dangerous drug and they've made it safer. The drug company turned it into a sublingual, so underneath your tongue, pellet that comes in almost like a Pez dispenser. So here you think, you told me this is going to be a good drug. That sounds like the perfect party drug. But what they've done is they've put a little thumbprint sensor on this, say, Pez dispenser, so that only the patient that it's been mapped to can dispense the dose. Hand it to your friend, or somebody else steals it out of your cabinet or something, they cannot activate the dose. So here's a way where we've taken an old drug and we've changed it into something safe. Another way we can do that is by adding binders to a drug. So if you, say, took oxycodone, made famous by OxyContin and the recent Netflix special called Painkiller, take this drug and you add some binders to it, where if it's crushed, it turns into almost like a paste or a gum. You can't snort it. And people who want to get high from this will typically grind up drugs and snort them, because the mucous membranes in the nose absorb it so quickly and they give that fast rush, where if you take it as a pill, it'll get you high, but it'll get you high so slowly that it's not as fun for the person who's taking it, let's say. So you can avoid at least one route of abuse by adding these excipients, these binders to it, to turn it into something that's unusable if you try to grind it up and snort. Or you could take an opiate and add a little conjugate to it, change the molecule such that it needs to go through the gut in order to cleave off part of this molecule to turn it into the active form. Again, you grind this drug up, you snort it, nothing's going to happen because it hasn't seen your gastric enzyme. So that's a cool one coming down the pike as well. Take a drug that we know, change the molecule just slightly, that after it goes through the gut, it turns into the active form. So that's enough about the opiates. Let's talk about what's cool coming down the pipe. Local anesthetics are the mainstay of our nerve blocks. Surgeons can numb up the surgical field if they want to. And several years ago, we as anesthesiologists were very excited when a new extended release bupivacaine called Exparel came out onto the market. And it was marketed as around a 72-hour drug. You give one dose of medicine, you get about 72 hours of numbness. Amazing. It works fairly well, but there's a problem, because at the surgical site, the drug might be there, but it might not be able to be used by the neuron. The reason for this is the local anesthetics need to be in an uncharged form in order to cross the cell membrane into the neuron, where they bind to the sodium channels within the neuron. So you've given a drug outside the cell environment, and you need to get it to cross the cell membrane to bind to the correct receptor where it's going to be active. And it needs to be in the uncharged form in order to cross that cell membrane. The problem is surgical sites tend to get acidic. Lactic acid tends to be released. They don't tend to have as great blood flow as you wish. So they tend to get this low pH that charges the bupivacaine. So the molecule is there. It's being released by the liposomes from the exparel. It just can't cross the cell membrane to bind to that sodium channel within the nerve. We came up with what might be a better product. What they did is they added some diclofenac to the liposome. So they've got bupivacaine and diclofenac within this liposome. Diclofenac is a non-steroidal anti-inflammatory. Decreases inflammation, keeps the pH normalized, so when the bupivacaine is released, it's in the proper form across the cell membrane. Kind of neat. Add a little drug to keep that local environment in that normal pH where you need it. Or another drug, rather than a liposome that releases the drug slowly. This is an oil-based extended release ropivacaine. Very similar to bupivacaine, slightly safer because of a better cardiac profile, but also a long-lasting local anesthetic that is very slowly released from this castor bean oil emulsion. And that, rather than injected or into the field or injected as a nerve block, this is this viscous oily substance that's actually delivered through a special delivery syringe at the site by the surgeon in the surgical field. Or you could take a local anesthetic and you could bind it to a collagen matrix. This is the Xeracol implant by Inacol. It's FDA approved for inguinal hernias. You open up the inguinal region, and as you're closing it, you put these little patches of bovine collagen that are impregnated with bupivacaine. As your body degrades the collagen, the bupivacaine is released and numbs up that area. So another cool way of delivering local anesthetics over time. Because the problem is, we can numb you up. We just can't numb you up long enough to keep you off oats during recovery. So these extended release formulations are very, very cool. Another way that we can work on nerves rather than nerve blocks is Pacira has a device called iovera, and it uses nitrous oxide canisters, which is a liquid at high pressures. And so think of like canned air. As you release that, it gets very cold. And so these are little needles that go in next to the nerve, and through a process called cryoneurolysis, they freeze the nerve and inactivate it for around 60 days or so. So, for example, if you're having a knee replacement, you can go in ahead of time, maybe a few days ahead of your surgery, and have this cryoneurolysis procedure done on some nerves that supply part of your knee. So for 60 days, those nerves are knocked out, but then the nerves regenerate. It's very cool. So 60 days while you're recovering, you've got this sensory block of your knee. Your knee is numb, but then it comes back once the surgical pain is gone. So that's kind of another way that we can specifically block more specific sodium channels is a drug called funapide. It binds to the NAV 1.7 receptor, which is kind of a special receptor. If you think of, maybe you've heard in the news about kids who are born who can't feel pain. This is almost certainly a loss of function mutation in the gene that encodes this sodium channel. Other people might have a gain of function of this sodium channel, and that's horrible. That causes this paroxysmal extreme pain syndrome. It's as bad as it sounds, where you're just always in pain because these receptors are constantly firing. So if we can block just those, that's kind of cool, because that in theory creates just a sensory block and not a motor block. So one of the problems with our nerve blocks is that we numb you up, but we also want you to use the limb. You get hand surgery and want you to bend that finger. We don't want it to lock in place, but maybe we've given you a nerve block where you cannot bend your fingers because we've knocked out those nerves. Well, what if we just knock out the sensory nerves but not the motor nerves? So that's cool. All right, so another way that pharmaceutical companies are addressing this, they're combining drugs. We have IV acetaminophen, and that has recently gone generic. A drug company has added an IV formulation of pregabalin, you might know it as Lyrica, to this. So you've got two different drug classes, the acetaminophen, but also pregabalin, similar to Neurontin or gabapentin. These nerve stabilizers, they're great for neuropathic pain in diabetics, for example. So combining different drugs to get the synergistic effect is also very effective. Another drug that's coming out is naproxen and pregabalin. So you've got naproxen, Aleve, and non-steroidal, similar to the diclofenac that they added to the liposomes, similar to ibuprofen. Everybody knows ibuprofen is Advil. But you take these two different classes of drugs and you get more than the sum of their parts in terms of their analgesia. Very effective. Another cool thing that that does is it avoids some of the GI side effects. When you've conjugated these drugs, they go through the gut a little more easily. These COX-2 inhibitors that cause ulcers or even a GI bleed are in their inactive form as they're going through the gut, and then are activated later where it's safer to have that. So that's nice. Another drug, clonidine, is combined with polylactic acid. Everybody knows that as what your 3D printer uses, but it's biocompatible.